Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to our first Podinar session of the day with Dr. Marty Jablow, also known as the America's Dental Technology Coach. Welcome, Dr. Jablow.
Thank you, Dr. Shah. How you been?
Wonderful. It's quite an honor to have you with us today.
Thank you.
So to introduce Dr. Marty Jablow to our audience, and today's topic is about artificial intelligence. Dr. Jablow is well known amongst our colleagues as America's Dental Technology Coach. Due to his extensive expertise in dental technologies, he's in high demand both as a lecturer worldwide and as a consultant to the manufacturer community. He's a member of the prestigious Celerant Best of Class Selection Committee, charged with the annual selection of the industry awards, and is the Chief Development Officer of Celerant Consulting Group, the dentistry's leading incubator and accelerator. Dr. Jablow has written articles for every major dental journal, including his own column and video series. He's president of Dental Tech Advisors, a dental consulting company. Educational-wise, he received his dental degree from Rutgers Dental School in 1986 and practices in Woodbridge, New Jersey, and has achieved various status with different academies, from fellowships of the AGD and the International Association of Dental Facial Aesthetics. He has been selected multiple times as one of Dentistry's Today's magazine's top lecturers, the one that we see usually at the end of the year. I see him every time on there. He holds membership in the American Dental Association and New Jersey Dental Association as a longtime member of his county's peer review committee. Wow, what a career, Dr. Jablow.
Yeah, I guess so. I think my mother probably would like to hear that stuff. I don't think most of the people here really care.
Oh, they will care, knowing what you have done and what you do. So Doc, tell us a little bit of background about you. How did you end up? How was dental school? How did you end up where you are today?
Well, that's a really interesting question that doesn't really have an answer. So I was always into technologies and different things. And even as a young boy, I mean, I got my ham amateur radio license at, I think it was 13 years old. So I was tinkering with electronics. That just kind of went through. And, you know, I take things apart and hopefully put them back together. I guess even in the late 80s, early 90s, I remember getting my first computer for my office, you know, and it cost a couple $1,000. And I think I broke it a few times.
What were you guys using? Flip disk at that time, right?
Yes, floppy disks. Yeah. The big ones too. They were big ones. And then we got literal floppy disks. But the good thing was I had people back then who knew what they were doing, and so when I screwed it up, they would come fix it for me. And eventually, I learned enough to be able to build my own computers back then, which were at that time less expensive. Now it's simpler to just buy them. But occasionally, I'll still tinker and put one together, depending on what I'm wanting to do. But yeah, so I kind of always was in that stuff. And then when I get to dental school, that kind of all disappeared. Didn't really think too much about any of this because now I had to, you know, become a dentist. And we all know what that takes and the time, effort, and everything else. And, you know, it wasn't high on my priorities. And then, you know, graduated dental school, got married, had kids, and all those other fun things. And, you know, what happens? Well, you get busy and this stuff falls to the side. So probably jumpstart a little less than a decade later. Or no, actually probably started in the early 90s when a bunch of us would get together on the internet. That was way before the World Wide Web, and it was all based on, there were things called Usenet groups, news groups, and we were all bunched up in the thing called science.medicine.dentistry. And these were early pioneers online, and we would get involved in that. And then eventually that grew to something called the Internet Dental Forum, which was the first one that was evolved, which was just emails back and forth. And it was good. And I met a lot of my friends. I met my partners, John Fluke and Paul Feuerstein, online, and the Internet Dental Forum. And then that kind of grew from there. And then we all started lecturing, and the rest, I guess, is history. Is they're now editors of technology and in major publications. I kind of come along for the ride sometimes, but so that's kind of how that evolved. And then I started lecturing, and as the lecturing got bigger and bigger, and obviously my name was associated with things, and the key opinion leader spots and all of that. And then we got to the next step, which was companies would come and try and hire me for my expertise in product development. I guess it's about 12 years now where Lou Schumann approached me and Paul and John to join the Best of Class committee when we selected these awards. And that's grown into something I could never have thought of, where we now, it's a big event. I mean, it's the biggest thing at the ADA conventions. We have about 10,000 plus square feet on the floor with a round lecture stage, and we select the winners, and we lecture, and we highlight all these products and new products, and we get access to a lot of things. And then from there, Lou started Sellerin Consulting, and once that started, we became quite a bit more involved with that portion of the industry. So I do a lot of consulting for startups, everywhere from startups to very large, corporations that everybody knows their names in dentistry. And, I get to have a lot of fun with it. But I would tell you, I never would have thought in a million years that this would have been something I'd be doing when I graduated dental school. I always used to say the last dental materials lecture I ever planned on seeing was the one in dental school before I graduated. You're shaking your head, right, Gator? Yeah,
I remember that one.
Yeah. And then here I was, decade or so, 15 years later, giving dental materials lectures to dentists. So you never know where the world's going to take you. You see your opportunities, and for everybody, whatever those opportunities are, take advantage of them. That's really what you want to do.
Sure. You have, as far as I can remember, I'm a little bit of a younger generation than you. For me, it started in 2006. And as far as I remember, I have seen you at every conference: Chicago, California, LA, New York. You and Paul Forrestine are everywhere.
Yeah, we're quite a bit around. I've spoken pretty much at every major conference in the United States, at least once, twice, whatever. I've cut that back now significantly because the consulting's taking on a greater role. But yeah, I've always been at those conferences since you've talked about, and I've seen you in many places, from Anaheim to New York to wherever. And it's always an interesting, event to see my friends and see colleagues and learn about the latest technologies. And it's good. Unfortunately, right now with COVID, we don't get to do those things, but you know what? It'll come back, I'm sure. And the thing, I don't miss the travel right now. What I do miss is the friends. And those friends are both, dentists, hygienists, assistants, and they go all the way down to my colleagues in the industry who some of them are very good friends. So, that'll come back. We're just not quite there yet, but I'm looking forward to post-COVID world.
I do also miss the camaraderie. You're correct. The travel, yes, that's not much missed. That's great. You guys did also some consulting work for me in the past, and yes, you guys are the leader in this space worldwide. But do you still find time to practice while you do all of these other business ventures?
Yeah, so I do practice. We worked all through COVID for emergencies, and then we hit that big opening, and I was treating patients 40 hours a week. At that point, I've cut that back again, thank goodness. But I'm a wet glove dentist, as they say. I can't talk the talk unless I walk the walk. So you know what? I'm like, even last week, I was playing with new materials and equipment, and consulting for a company. Things weren't working the way they're supposed to, and my job is to tell them where the weak points are and try and fix them, all along with not endangering my patients. And these are all approved devices, but or materials, but we want to make sure when it gets into the hands of any dentist that they're going to be successful in using the products. Well, I'm on that bleeding edge. I've stayed on that bleeding edge because I live there, but I wouldn't recommend most people do that because it creates some anxiety, I will tell you at times.
Wow. So yeah, this is good. You guys do quality control. What do you like more? Not to put you in a spot, but dentistry or consulting with big players?
Well, I like consulting with the startups. That's more. I like that better because that's where things change. That's where everything is nimble. That's where people can make quick changes and you see them. Working with big companies isn't quite the same way because they move like dental schools, at a glacier pace. They're a little bit better than dental schools, but it still moves slowly. A lot of times you can't. There's too many levels of people, and you have to deal with it that way. But overall, I like the consulting part, but I also like treating my patients. So I have to find that perfect balance, as everyone would say, between the consulting and the patient treatment. But I also feel that if I'm not treating patients and using this technology, then my voice isn't real. It's not true. And like I said, if I'm going to talk the talk, I better be able to walk the walk. So when somebody says to me, does this work? I can sit there and look them in the eye and say, yes, I've used it. I've treated patients with it and it works, versus, yes, I heard good things about it.
Smart way of doing it. I understand both you and also Dr. Forrestine practice. Very much respect. So it's not easy to wear all the hats in the practice and also all the hats in the corporate, but we're used to that kind of thing as dentists, as you know.
Yeah, I mean, as I talk to people, I say wear many hats, both inside and outside of dentistry. Got lots of titles. Only one matters, and that's daddy. Two people get to call me that, but the rest of them, you know what? Those are accolades, and they're okay. But in the big picture, family matters, and the rest of it falls aside. So first things first, and then you get to play with all this other stuff. You've been involved in developing product. You know what it's like, the time it takes to get away from family and all of those things. And sometimes we need that perspective thrown back at us.
It's not easy, and you can't do it by yourself. I've tried. You got to seek help, experts, patents, IP, and testing, and all of that good stuff. 510K, all these. And
oh yeah, I've been through it all too many times. Yeah. And then we'll make that transition now, because I think that's a good segue into the AI stuff, where for over, now it's probably 4+ years I've been playing in the AI space with consulting for different companies, waiting for them to develop product, see what those products look like and how they're going to bring them to market. There's some issues along the way. Some of them are more difficult than others to overcome. But, AI is going to absolutely change the way we do dentistry, how we diagnose. And the fact is, we're using a lot of AI today. We just don't see it and realize it and how it works.
Especially in the management softwares, I presume. So AI, interesting topic. I think a lot of the viewers will be excited about this. Every time I see you at a conference in a different year, I walk away with more knowledge and information. How do we keep up with the ever changing? Every year it's something different, something new, something improved. What do you say to somebody that's doing bread and butter dentistry that wants to get into digital and AI and things?
See, like every other thing there is, we always have to look at what's the benefit. What's the return on my investment? How's it going to make my life better, more efficient? In some cases, make me more money. In some cases, it's just having more fun. But you have to always have that perspective. I call it the bell curve, like we've all seen. And, people don't always want to be, or should they be, on the bleeding edge. Bleeding edge costs you a lot of money. Bleeding edge costs you a lot of time and aggravation, stomach lining, and everything else. And you have to understand where that is. Now, in many cases, even in my own practice, although I have access to a lot of different technologies and can incorporate them, I don't. And the reason is, not everything is meant to be in my practice. And, sometimes it's funny where dentists will call my office and ask, not to talk to me, but just what is he using for sensors, or what's he using for intraoral scanning, or what's he using? And they don't even they just assume that if it's good enough for me, it's good enough for them. but that's not the way to approach it. The approach is, where do I think I need benefits, and what are those benefits going to be for me, whether they be AI or any other dental technology, and what's going to happen from there. I mean, I talk about a year ago, one of my intraoral scanner got dropped, okay, and it shattered the lens, and we were without. And the biggest stress point now became taking an impression. Now, I had taken regular impressions for with polyvinyl for 30 years. And now all of a sudden I had to do it again. And it was like, oh my God, how do I do that? This is all of a sudden which I did for 30 years and successfully did, became a stress point. Why? Because I became so dependent on my technology, my intraoral scanner, what's it going to do? And then when you look at it, and then we'll talk a little bit here, is that most people don't realize, again, where AI may come into their world. So originally, when you took an intraoral scan using almost anybody's scanner, it was just picking up information. I'm a 3Shape Trios user, and you can turn on what's called the AI, and what it does is it takes the soft tissue out. It eliminates a lot of the things that I used to go back and trim the models, as I would say, digitally. But, they're able to do things. If you get a little seepage of blood and and at first it doesn't see that, and then all of a sudden it starts seeping in, but you go back over, it doesn't find that now. And the reason is the AI says the red doesn't belong. And so there's a lot of different things that we now see AI getting incorporated to that people don't even realize. In fact, if I'm doing a soft tissue case, I'm doing some kind of denture case, I turn the AI off in the software. And the reason is I want to collect more data on soft tissue, not more. And so you have to understand the technology and how it's going to work for you. You can't just say, I'm going to use this. You have to understand it. And it doesn't matter what technology that is. In this case, it's an AI that's helping you take a better impression, but sometimes it's not going to. So you may want to turn it off. And these become the plays that you have to make in how you're going to better do dentistry, and go, if you're into the digital dentistry world, how you're going to get through it. Because right now, most people who are doing a lot of digital dentistry are early adopters. I mean, there's only about 10% or so of dentists in the United States who are, doing intraoral scans right now. And we have to understand that. And many of us are developing protocols and different ways of doing things, that we would never have done before. An example is the other day, I had a patient come in with a disastrous dentition that needs full upper and full lower dentures. And in the past, that would have meant extracting the posterior teeth and going through the whole normal thing that I was taught in dental school. I'm sure you may have been taught that too. Let some healing. Oh no, I just scanned the whole thing. I've got the bite. I've got everything I need. And it's, you know what? Let's just go to finish. And that becomes the trust factor. When you can develop to the point with your digital that you know that you've got it. Or when you turn around and do a full arch and you send it to the lab and there's no bite. But you tell them, go for it, because you got to trust the technology. And that goes back to my first little piece of technology with a Cavo Diagnodent, probably around the year 2000, or maybe a little after that, where, you had to try it and see if it was real and did it work. And then once you gain the trust, then you start to learn how to best use those technologies. But like I said, there's AI benefits. And then in that scanning, there was AI turn it off. So It just depends what you want to do with it.
So I've been talking to some medical doctors that are working on microscopes that actually tell the surgeon which artery, what to cut and what to suture. Is that coming to dentistry?
Yeah, well, we have some of that right now that we're looking at. And yes, I mean, we can talk about that on different levels. So let's start looking at it. So we have let's start with the easy stuff first, all right, which is non-clinical. All right, there's a bunch of AI that's out there right now that does this things. And what that does is it looks at your software packages. It looks at your appointment book. It may look at your schedule. It may be looking at unscheduled treatment. And it's trying to merge all of that stuff together. And, that's a benefit for the front desk, where we can then hopefully, send directed emails, look at your usage. This is stuff that a lot of dentists don't do. When do you start looking at your schedule? Well, if you're only looking at today and tomorrow, it's lost opportunity because you never get to fill that schedule. And with that, you can use some of these technologies to actually have it look at all the different aspects of that and then bring it all together. There's other things that it's going to wind up doing. And some of these examples are not ready for prime time, but they actually work in terms of, let's just say I had a patient yesterday and I put in a composite number 30 MOD, or for everybody around the world, lower right, first molar, or, 4-6, depending on where you're looking. Okay. But we have this, and the patient calls the next day or after hours. What if we had an AI that looks in the chart that says, okay, we know the patient was in yesterday. This is the procedure done. And the patient explains it as it hurts the hot or cold. What would be the response? Well, we can have AI actually respond to that based on, the parameters that we set. So, we would mostly assume that it's either occlusal trauma or deep caries or whatever that may be. But then the AI could respond in a natural voice, just like yours or mine. In fact, they could even duplicate it. And they could respond back that says, okay, if you're only having short pain, last 1 or 2 seconds, this is not abnormal. Okay, if it continues for 2 days, call you off. I mean, things like that. We could even have it follow up with the patient. Where there is AI that does interactive conversations. Some of us may see that as chatbots now, where we see a lot of chatbots in dentistry on web pages, where it's actually using AI to look at questions over time. And you got to remember, it's all big data. So what we're doing is we're looking at all of those questions that come in and what are the appropriate answers for them. And again, they fit into pretty, most things fit into a pretty good box. The round peg goes in the round hole, the square one goes into the square one. And we can use those things to help us develop, responses to patients so that it becomes more efficient. They can get good information, 24/7, 365, and, it's always consistent. I'm sure in your office, my office, and everybody else's office, if you call and speak to one person, you may not get that same consistent answer across the board. The same way you won't get a consistent answer with the docs, but you want that consistency. And if you can use AI to drive it, that'll definitely work. The same thing that happens when we've all called the disastrous tech support, no matter what company, no matter where, and they walk you through each level because there's a screen popping up trying to get them through a workflow. With AI, that becomes a little bit more efficient, and we can, jump to it. But yeah, we can do some of this stuff now. It's not ready to be totally integrated into most people's offices at this point, but we have that ability that we can, triage patients or manage their insurance and all different things through AI that we're currently not doing.
So when do you think it's going to be more mainstream in dental? I mean, you're talking about management software, you're talking about robotic assisted surgeries, you're talking about microscopes, you're talking about integration of all these things. What do you think is going to be like in the next 10 to 20 years? Every year it's advancing more rapidly.
Yeah, so I kind of use the same thing all the time. When I graduated from dental school in 1986, and probably I call it the 5 years that it takes to really learn to be a dentist after dental school.
Yeah.
Okay. Everybody knows what we're talking about. We come out and the whole idea of being licensed is you're not dangerous to the public. Then you get good. All right. Hopefully you get good.
Maybe a little dangerous.
Yeah, and you learn a little bit more and a little bit more and a little bit more, and experience takes over. That's really what it becomes. So we get this experience, and then what do we do with it? Well, we have to figure it out. And when we do that, you know, we find our niches, we find what we like to do, and we hopefully become good at it. But there's things that we still have a bell curve, no matter what it is. And what we want to drive is consistency. And I think AI is going to help us do that. And whether, you know, initially it's going to be in diagnosis. So about 20 on this standard bite wing radiographs, I mean, nothing fancy. There's over a 20% error rate. Okay. That's just human nature. You know, how good is the radiograph? How long did you take to look at it? What monitor did you look at it on? Because that can matter. What's the lighting in the room? Remember when they told us to read radiographs, they wanted to put you in a dark room with, you know, with everything. Well, that doesn't happen.
What angle you have the X-ray?
Oh, yeah, if you're looking up at the monitor, down at the monitor, you know, there's times I look at, you know, radiographs and I go, how did I miss that? There was no way to miss it, you know, but you did. And because that's part of being human. So what happens is, in many cases, and I think this is where we're going to see some starting in AI, and this is one of the few places where I've done quite a bit of consulting, is in soft tissue and hard tissue pathology. And when we look at that, you know, we're going to see things where 24/7, 365, the machine can be consistent in reading a radiograph. All right. That is better than any human being can do, because we fatigue, we get tired, our eyes, you know, don't adjust. And I know, even, like I said, I've read thousands and thousands and annotated thousands of radiographs for these AI projects. And you can only do it for so long before it just gets to be monotonous, time consuming, tired. So what happens is the AI doesn't do that. So once we take this big data sets, and that's lots, it's thousands and thousands of radiographs, that's not what it's trained on. It's trained on a smaller number, but once we start developing these into thousands and tens of thousands and hundreds of thousands of radiographs, we now can then be more consistent in what it's going to be. So going forward, as I tell everybody, whether it was a cavo diagonal dent, whether it's any caries detection machine, the diagnosis is still based on a human being. All right. You have to understand that it's a human being, and not everything should be read as an absolute. And that includes with AI. Just because it looks like a cavity doesn't mean it is. Just because you think it's a cavity, and it may be by definition, doesn't mean you need to treat it. All right. I mean, if you have a small occlusal in a 65-year-old, and they've got no other restorations in their mouth, and yes, it's through the DEJ, but it hasn't progressed, and you've been treating it for 10 years and hasn't progressed, I'm not drilling that. It would have been a problem decades ago if it was going to be a problem. But, you know, in a 12-year-old with, or 20-year-old with a bunch of, you know, restored teeth, I'm going to jump in. The idea right now for using AI and caries detection is really for it to be able to tell us as a second set of eyes. All right. Think of it as a, you know, that secondary consult, independent of us, where to look. And by looking at these areas a second time, you know, it gives us a better understanding of what's there. It may point us to things that are subtleties that we're missing. It's the same idea of, you know, people have used cancer detection devices, yes, you know, like a Velscope. And Velscope is not a test. It's just an enhanced screening device. Well, right now we're going to be looking at AI as those enhanced screening devices, where we're going to take a second look at it, but instead of using a human being to do it, we're going to use a computer to do it. And those secondary looks are really the important part, because now we can start developing better consistency in our diagnosis. And we get better treatment.
Better detection for cancer screening, less fraud, management softwares and billing, and
absolutely. So the insurance industry looks at AI differently than a dentist would, or medicine does. And the insurance industry is looking for it for fraud detection. It's also looking to reduce workforce. All right. So what happens is, when we look at all of those things, they're looking at it going, okay, if we have a pre-op, a post-op, does it fit the criteria that we're going to develop through AI to send it through? So if they can more efficiently process their claims, you got to remember, this isn't about patient treatment now. This is just about how do we become more efficient as a company. Well, if they don't need to review as many radiographs, or it can flag things that people weren't seeing otherwise, these are ways to benefit an insurance company. With that same stuff, we can also look at it as how does it benefit, the patient? Well, the patient gets an independent look. We get better consistent diagnosis. We may get earlier interventions where necessary. And obviously we know there may be things coming in the future, the different products, at least I know some in the pipeline, that may actually change how we actually treat a carious lesion.
Speaking of that, this is a very important topic. There's a big debate, Marty, about doctors diagnosing caries. For example, one tool will say it shoots something in there and detects the density. One person says your Explorer has to catch and it has to be soft, and then you got the next guy that says, well, if it's black, I'm going to open it as a preventative measure. What's AI going to say?
Well, that's going to be a good question. So first of all, Explorers, although that's what I was taught in dental school, and that was what probably you were taught in dental school, they are poor, and that's giving them credit for something in terms of diagnosing caries. All right, you're probably going to miss 75% of caries if you're going to use an Explorer as. And I do a caries detection lecture, and I have the research to back that up. You get probably about a 75% error rate.
Wow.
Okay. So, you're doing things for reasons that are ancient. All right. I mean, there's a whole great story about why you use a Sharp Explorer back in the olden days. And these were pre-carbide burrs because we couldn't cut enamel efficiently with slow speed handpieces. And so we had to make sure that the thing was big enough, and we had lots of caries back then, to open up a hole. Well, if you stuck an Explorer in, it went through the hole. And then you could get a stainless steel burr in there and kind of rip through it. But, these are the things that we look at and go, okay, again, back to consistency. And once we get that consistency in diagnosis, we're also going to get a consistency in treatment, because we're going to be able ultimately, and we're nowhere close to this, so don't think this is around the corner, where we're going to know if you get into a tooth at this point in time with this restorative material, that we have an 80, 90, 100% rate of cure in some cases, where we can, where we may be able to seal things that are non-cavitated. Well, all of this technology doesn't exist, but the whole idea is that we can develop protocols from better diagnosis that will then enhance what we do. A different example of using some of this type of learning is where you could get feedback from a handpiece. Let's say when you're placing a implant, we know if you place a Zimmer or a Biomed or whatever, this type of implant in this type of bone at this Newton centimeter resistance, what's our success rates? And so where unfortunately many dentists, we all, and I'm no different, we have that go-to in our office. This is what we use. What happens when we get into a situation where that's not the best thing to use, but that's what we have in our office? So we're going to wind up at some point, having AI look at a cone beam scan with, determining bone density, with looking at the actual implant that you plan on using, and what are the parameters that the AI is expecting, and does it tell you to do something different? In other words, I want to torque it in. What's the best torque to put it in at? It may not be to torque it as high as you want, okay? But it may be something less. Or you should, I want an osteotomy that's a little bit bigger or a little bit smaller based on my bone density. And so all of those things can come into play as part of our treatment planning using AI. And they may say, well, you know what? I don't think that's, outcome is better if you use, this Nobel versus that Zimmer. And then you can pick and choose the best implant right now for that surgical situation. And these are just different ways that AI is going to just totally revamp what we do in dentistry.
Amazing. What is your take on Claronav and Yomi? Those two things that are.
Yeah, so Yomi, again, it's a cool thing to play with. I've played with it, not on a patient. I've done the demos at meetings, and robotics is going to be part of dentistry. We're just not there yet. I mean, those things are on a very elementary level at this point. I mean, the whole idea of that is just, and there was products before these, but not as robotic. They've been manual, where they'll take CBCT data and, it's guided restorations. Okay. This is taking it to the next level, where you're having a computer telling you what position you're in. Are you in the right position? And in some ways right now, this is to eliminate the need for a guide. You're doing the guide manually or digitally. But when I look at some of those things, yeah, these are the beginnings of what that's going to be, where we need to look at miniaturization of some of the dental handpieces and things like that, where, we look at, it's funny because, when we, in the United States anyway, we mostly use air-driven handpieces, not electric. Whereas, when we want to mill something or we want to place an implant, we're using an electric handpiece. So, we can get good data from electric handpieces, whether they're, controlled by a person directly, manually, or whether it's going to be computer guided, where we're going to be able to place these things. There may be a stent or a guide, and you just place it in, and then the computer can go do what it needs to do while you're observing and setting parameters. But these are all parts of AI that are coming. The robotics are just going to be another portion to that, where we're going to be able to use those robotics in ways that we currently can't do. And think about this. We all know that everybody doesn't have great hands. We knew that from dental school. We know that in practice. But you know what? Robotics may change that. That smart guy may be just as good as the guy who's not as bright, because the AI is helping him out through it. And the guy whose hand is a little shaky is not going to be shaky anymore. So, robotic surgery is going to have their places. The parameters to use it are going to change over time. And, I went back to that stuff I did early on, and like when I got out of dental school, and what I look at what I did out of dental school, I thought was state of the art. Okay. I look at what I did out of dental school now, and it was barbaric. Okay. There isn't a single procedure right now that I go to start that I do the way I was taught in dental school. Not a single one. All right.
And so you're not shooting some gold in
No, I'm not. You know what? I was at the very end of gold foil and that. But yeah, you're not doing that kind of thing. And even, from my injections and nothing is done the way I was taught in dental school. That doesn't mean the tenets of what I was taught weren't good. What it means is that we've progressed in a way to make things better. And with that, so like I say, so what's going to happen is in 15 or 20 years, when I decide that I'm no longer doing this anymore, or maybe AI and robotics will allow me to do it well beyond what I would have normally been capable of doing, I'll look back at 20 years ago and go, wow, what's state of the art today is barbaric. I mean, what we do, is just different. I mean, when you think about it, when I first started doing implant restorations, all right, or even implant placement, people were scrubbing rooms like an OR, and you tracked every case and you needed to know every piece of the puzzle. And now it's commonplace. It's not just oral surgeons and periodontists, it's general dentists and guided surgery who can make somebody who wasn't that good that much better. And they allow them to do things that they wouldn't have done otherwise. So, this is an evolution. AI and robotics are just going to be part of that evolution that will allow us to do, like I said, better, more consistent treatment on our patients than we ever could imagine, or my dental school instructors would ever have thought possible. I mean, think about the guy who was teaching dental school in the 1940s and 1950s. Think about bonding. It didn't exist. It was a pipe dream.
Yep.
Then it wasn't. And now it's mainstream. Implants, have become mainstream. What we're going to do next is mainstream? I don't know. We'll see.
Wow. So what what do you say? Okay, two questions actually. What do you, if you can address that, where do we start, and what do you say to the guy that went and bought some sort of a digital impression scanner and tried it for a couple of times and got frustrated that they couldn't get the margins or what have you, or get hemostasis, and then they went back to the impression technique? I've heard those stories as well. What do you say to these colleagues?
So when we get to that digital impression stuff, there's an old adage in computers: garbage in, garbage out. Okay, and that's what it becomes. You have to develop the techniques that go along with the technologies to make them work, or you need the adjunct tools to make that better. All right. Now, there's some people who will say that you need to, they're doing digital impressions and they want you to pack cord. They'll do one to cord techniques, two cord techniques, whatever. Then there's the other camp that says, I don't pack cord. Then there's another camp that says, well, just take a laser, go around the tooth, do a little troughing, and you can see your margins. The problem is, in many cases, is we cannot get the dentist to mark their own margins. All right. And this is a part of AI that's available now. When you go, if you're not marked, first thing, I don't care what system you use. I don't care how good you think you are. Please, 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 if you use an intraoral scanner, please mark your own margins for the lab tech. It takes minimal amounts of time. There's no excuse for not doing it, because guess what? Your restorations will be better. That margin at that moment better than anybody. And when you send these digital scans to the lab, there's the ones that are easy to read and they go right through. And then there's the guy in the lab who reads the difficult margins. Okay? And he's got to mark them. And he's trying to do the best he can. Whereas if you've just done that, and there have been times when I've looked back in a tooth while I'm marking a margin and I'm going, okay, where is it? And I can now look at the tooth, look at the margin on the scan, and appropriately set the margin. So again, this is about training. It's not using old world techniques, although cord can be an old world technique, in a new world. And that digital world is the new world. So you have to figure out how to adapt to it. So, whether that's a feather margin, whether it's a chamfer, a butt joint, I'd avoid trying to do beveled, margins that I used to do with, PFMs for years. You have to be able to look at those margins and see them. It's a camera right now. And if you can't see that margin, the camera can't see the margin. So, you still need good hemostasis. There's tricks around some of this stuff. You can get an assistant to blow air while you're scanning and there's no blood over the margin. You can capture the margin. I was talking about the AI portion of that before. If it doesn't see it the first pass and it is a little seeps back later, it's not going to be there and you can still mark your margins. You have to develop your own workflows, but with that comes training. And how are you going to do that? I mean, it's no different than anything else, whether you want to train tissue for an implant, whether you're training tissue for a 3-unit bridge. These are all just techniques that you have to do. So I always tell people, if you want to avoid the problems, mark your own margins. Don't send it off to a third party that you hope will get the margin right. In the old days, at least in my office, if that margin isn't right, I don't have anybody to blame but me. Okay? That's it. Bottom line stops at me, versus in the old days, well, it was a lab error. And what you see right now is, if you are doing intraoral scans, you do see better fit and you will see more consistent results with less time to adjust the crowns. I mean, in the old days, I'd put in a full arch restorations and it would take me an hour and a half, and there was adjusting and everything else. Most of the time it's drop in, a couple of adjustments, and patient's out in a half an hour. I mean, whether it's 1 unit, whether it's 5 units, whether it's 10 units, we've got that precision that we didn't have. When you think about in an analog world, what we had was, and this is the dental materials lecture again. So we went through, we took an impression, which was not 100% accurate. Then we had stone, which if you didn't mix it up, that the expansion and contraction was off. How we did good dentistry, I still don't know, but we did. And now we've got better dentistry. Can't hear you.
usually we say that the lab will get you out of trouble.
Yeah, well, but you know what? In the digital world, the lab can help you, but again, you shouldn't get yourself into trouble in the first place. All right. The first thing, no matter what that is keep out of trouble. So, if like here, it's AI software and everything else going on. Do I have draw on the bridge? I have a thing that I click a button and it tells me if I have undercuts. This was not available in an analog world, especially when if we're talking about a 3-unit bridge, it may not matter so much. But if we're talking about long span, different things, we want to know that we've got good draw. And maybe, if I look at that and I go back to it and I go, okay, you know what? It's going to take me another 30 seconds of prepping to get rid of that undercut, and things just going to seat, whereas I'm going to have to struggle to put it on, or I'm going to cause stress in a restoration, whether that be a PFM, or zirconia. We've got to look at all of those things. And, most failures aren't material, they're diagnostic, and that's something that we really want to look at is what is that diagnostic? And if we know that there's certain things, like we all know, if we do that big anterior bridge, where's the stress point? Well, the stress point we know is at the canine. All right. Porcelain pops off either the canine or the lateral, or we wind up where we get a fracture there, even in zirconia. So you have to prep these things a little differently. And, that becomes just experience and everything else. But out of trouble is usually diagnostic.
Sure. So, Doc, now as to the audience, if they wanted to get started, we put your URL up, dentaltechnologycoach.com, where you can reach Dr. Jablow. Tell us if there are courses. What call to action would you have for our colleagues to get started? The ones that are still doing the conventional triple tray and all of that.
Yeah. Hey, listen, I was there for a long time. I did that stuff just like everybody else. But so what I would say is this: if you're looking to go digital, there's a lot of classes you can take. There's a lot of people who do good. It's not me. That's not where I'm at right now, teaching that kind of stuff. But, I would say to people, look at what the niche product right now that I think everybody should be heading toward is an intraoral scanner. And, the price points on them are now somewhere between 18 and 25 to get you in, and 40 for the top of the line, Trios 4 or Prime Scans by Sirona. But you can get into a decent one, the Medit 500 or those. There's some decent ones that are out there that are going to do the job. And what I would recommend is find users, find Facebook groups, that are all for these products. So you can go in there and look and see where solutions are. I just, in fact, not in dentistry, but I had a technology project here in my house, and I was running into a problem with something, and I found a good Facebook group, and people helped me through it. And that's one of that camaraderie and the ability to help people is there. Find a mentor, find somebody local who you can talk to, and maybe go and watch them do a couple of cases so you feel confident in using the software. So I would, there's plenty of companies will offer good training. And remember, training matters. Whether you think you can do it without training or not, training matters. Get the most out of your software. So I would highly recommend that don't cheap out on that extra $1,000 and get the training that you need from your intraoral scanner company. With that, whether you're into 3D printing or, other parts as we go down these digital ways, it's all the same thing. What's the benefit? How are we going to get there? What are we going to do with it in the end? And, you don't want to be on the bleeding edge. You don't want to be on the dinosaur edge, as I'll call it, which is the other side of that curve. You want to be somewhere in the middle where this becomes mainstream. At this point, I think, intraoral scanners are mainstream. They're very easy to use, and they're simple, and the patients like it. I'm going to tell you that. I mean, patients love that. They love looking. I've got a 48-inch monitor or something on the wall in front of us, and I've got 3 monitors in my office when we take in a scan. So no matter how I want to position myself, I can watch the scan. But I always sit them up and show that to them afterwards on the big screen, and they love that. They, and the thing's already at the lab before they even left the operatory because I clicked the send button and it's there. And, 4 days later, I get a crown back. So these are the things that we want to make sure that we talk about to the patients and show them the benefits. And, that's really where it's at. You don't want to be too far behind, but you don't want to be the first one either. So stay off the bleeding edge. I live there. It's not the place most dentists want to be, but you don't want to be on the trailing edge either. And then when we look at trailing edge, we still don't have 100% digital radiography in this country. So, there's still people taking film, but that's kind of it. So I would tell you, look on YouTube also. There's lots of good videos on people teaching and learning this stuff. When it comes to AI, we're still not out there with enough stuff for most people to look at it. But we're not too far away from that. I would expect there'd be a big AI explosion in the next 2 to 3 years.
Wow. I hope that it doesn't put us out of a job. But on that note, also Rick Ferguson, Michael Scherer, and Ken Serrano, and many others have come on the show that have had a similar message for our audience. And they're also good educators. So if they if they have ideas, our colleagues, and there's a lot of them that are going to be tuning in to this webinar, if they're interested in getting consulting from you, what's the process?
All right. So I don't consult for dentists. Okay. I'm not going to consult I'll do it occasionally, but it's not something I normally do where I'm going to come in and do your technology evaluation and tell you what you should buy. I can help you. If you've got a specific question, I'm happy to answer that. You can get to me from either the website, dentaltechnologycoach.com, or marty@dentaltechnologycoach.com. If you want to email me or just Google me in some way, I'll come up somewhere and there'll be a link somewhere to get to me. But if you've got ideas, we've got those entrepreneurs out there, those people who are looking to do some kind of product. You and I even talked about some of that earlier, years back. That's my niche right now. I want to help entrepreneurs come to market, see what they need. How are we going to help them and bring these new products to market for the benefit of both our patients and our dental practices? And that to me is really kind of where I like to be right now. So I like that, the entrepreneur stuff. And I'm happy I spend a lot of time with people with ideas. Unfortunately, my job is to also shoot them down, but because a lot of people haven't thought through their ideas properly, but that's the guidance we get. And, I might go through as the fairy tale says, you're going to kiss a lot of frogs till you find that princess or whatever. It was the prince. I'm not kidding, but you get the idea. So I'll talk to a lot of people and they may disappear for 2 or 3 years and they come back to me and go, I took what you said to heart. I figured it out. Here's my prototype. What do I do next? And now I can get a client, whereas I didn't have one before.
That's wonderful. Marty, technology, I had a very pleasant experience with you. Actually, you did give me some pointers that helped me a lot. So for companies, what I meant with actual dentists, not their practices, but if they had AI technology ideas and wanted to, the companies from startup where your core competency is, to reach out to you under that URL, dentaltechnologycoach.com. Very exciting stuff. So one comment on the side here says, just do it when it comes to making the transfer from the PVS to the digital world.
Oh, absolutely. Just do it. Like I said, now if I have to take a Crown Bridge impression, it's a stress point. So I don't need any more stress.
That's great. That's the logistics is amazing. You send it to the lab, they send you a crown a day or two later. Do you use CEREC yourself?
No, I've never been a CEREC user. I've never been a mill user. Okay. And because I just didn't see how it fit into my my workflow. All right. It wasn't something that I've looked at it. I played with the technology. I had one in my mouth for a couple of decades that was done. It was probably, let me think, that was 2007. We did an article, me and John Fluke at his office for New York Times. And so I had a CEREC done that day, and it lasted up until I think about a year ago. So it's probably 12 years or so. The restoration was fine. My tooth was the problem. But you know, that's really it. I mean, it works. It's good technology, but again, you know, I don't necessarily agree with what they always say, where, well, get your assistant to do it. It's gotten a lot better. AI has helped in restorations. And like I said, they're using AI to even mark margins on teeth. But, you know, there's not a one size fits all in dentistry. And that mill, as good as it may be, is not the same as the $1 million mill that they're, you know, making your other restorations on. It just depends. I've seen some amazing CEREC restorations, and then I've seen some not so good restorations, especially being on peer review for 30 plus years. Wow. But I wouldn't tell anybody not to do it, but does it fit what you need? We'll look at your ROIs. It just never fit the ROI for my office.
You make a very good point. From the business perspective, I'm more of an MBA business kind of guy. I'm looking at the model and tying up your chair for that long, running and staining things and marking margins. And just from the economic perspective of having a good flow in the practice, it kind of would be distracting in my opinion. But again, maybe I'm wrong. And to have that equipment, it is a good marketing function, I presume, that, you know, patients see you're milling your own thing and you get more referrals that way. But is it in the best interest of the patient, or would it be better if an expert technician was doing it, is the question that we would have to answer for our own offices.
Yeah, and with that, when I look at that stuff, is, you know, you have to, what they look at is, and back when CEREC, way back, they used to, you know, when I was first out of dental school, crowns were $175 to $250 a unit. Okay. Well, we're not looking at that now. You know, we're looking at $100 units or less. So, you know, you have to do double the amount of crowns to justify those expenses, because they have not come down. The total package has not. So when we look at it, we look at about a $50,000 mill. Can we justify and amortize with your, you know, as we get to, can we amortize that expense? And, you know, I have a $30 block, and now where does that all go? And that's something that we need to look at and just be aware of, is look at the money, look at, does it make sense? If for some people it may, and it may just be fun, in which case do it. But for most of us, I don't think that fits into that category.
I agree. Wonderful technology, improving well, does really well in the labs as well. Some of our colleagues love it, some don't, and one has to decide for themselves. But again, amazing technology and amazing things coming to dentistry. So you've been at it for over 30 years.
Yeah.
What do you think this profession is going to look like in 30?
In another 30?
Technicians doing the programming for the AI, or?
I think I can't even tell you what 30 years is going to look like from here. I really don't know. I think that ultimately we're going to have a digital patient, and we're going to hold their head in our hands, and you're going to be able to flip it. I mean, the ultimate goal is to track the patient from birth through death. And we would then see, okay, here's a radiograph that shows us caries. Here's was the restoration. Here's what happened after that. 3 or 5 years later, when they came back into the system, they had recurrent decay, and we could see it on the radiographs. And then we see the restorations, and then we can track the tooth from eruption through extraction potentially, or hopefully not. But that's what I see, where you're going to take this head and turn it around and look at it in ways that we just can't even imagine. I mean, think about 3D right now. You know, when I graduated 30 years ago, 3D was not even a thought. Okay? It is today.
It wasn't going to happen, yes.
Yeah, it wasn't even a thought. Now it's mainstream, you know? And that's what we're going to look at. Now is, you know, we talk about the disease process. It'll change. The way we treat things are going to change. We may even still eventually be able to regrow teeth. Who knows?
Yes, the stem cell front too. You add that to the digital and the robotics and the AI. Yeah. It should be very, very exciting. But ultimately, it helps patients. It helps us diagnose better. It decreases management burden. So do you think that the software will eventually be to a point where management companies will be less needed for our colleagues to be able to prosper in their practices?
Yes, eventually, you know, we're going to look at software-based, you know, consulting. But if all this works the way it's supposed to, It should just work.
It should just work.
Yeah. So I think AI is going to change everything. It's going to change humanity. That's really where it comes down to. It's going to change humanity.
Change humanity for the better.
For worse, I can't tell you, but it's going to change humanity.
If we can balance the changing of the humanity with maintaining our profession's autonomy, that would be a real winner.
It would be, but like I said, time will tell.
Time will tell. Dr. Jablow, thank you so much for your time today on a Saturday to join us and contribute free knowledge and education to our colleagues across the world. We would love to invite you back on the show on an annual basis to give us a report on how we're progressing and what tips and tricks you might have for our colleagues. We get a tremendous viewership on the weekends that exceeds sometimes 100, 150,000 colleagues across the world. So I'm sure they're very appreciative of the time you've taken to join us today. Thank you so much, Dr. Jablow.
You're very welcome. It's a pleasure spending time with you and everybody who logged in and who logs in the future. And again, if you got a question, happy to try and answer it. Marty at dentaltechnologycoach.com.
Wonderful. I'll be sending you some inquiries here pretty shortly, actually. Thank you so much, Marty. Have a great Saturday, okay?
You do the same. So long, everybody.
Take care.